Hello and welcome. Today we will be discussing urinary elimination and catheterization. Normally we would have you break into small groups and review each of these urinary function terminology and make sure that you are able to differentiate between all of them. I will allow you time to review urinary retention, equipment, and incontinence terminology. And if you go to the next slide, it actually matches up for each urinary function, terminology, or equipment, the definition of them. If you have any questions on this, please make sure to ask in lab and we can review that with you. Again, here are the definitions for each of the topics covered on the previous slide. If you have any questions on these or are looking for a way to better understand them, please make sure to bring those questions to lab. What is the definition of urinary catheterization? Urinary catheterization is the introduction of a catheter, which is a pliable tube, through the urethra into the urinary bladder for the purpose of withdrawing urine. So what is the difference between applying an external catheter and inserting an indwelling or straight catheter? The condom catheter, which is an external catheter, it's a clean procedure. We use medical asepsis for this, and it is applied to the external penis. The indwelling catheter, however, it's a sterile procedure using surgical asepsis and is inserted into the bladder through the urinary meatus. Straight catheters are used for immediate drainage of the bladder, then the catheter is removed. It's used to relieve retention, which may have specific orders for use in any urinary catheter if the output is greater than a certain amount. It's used to empty the bladder intermittently. We would want to make sure that we're checking our agency policy for this. There is a maximum amount of urine to be drained at one time. If we drain too much urine too fast and the bladder was overfilled and all of a sudden it's like a balloon, it deflates. So it goes from being very large to being very small. You can actually cause bladder spasms when that happens. Straight catheters can be used to obtain a specimen as well. I believe we covered that in Nursing 1. It's usually when we cannot obtain a specimen through other means. So if a client is incontinent and is confused, is unable to follow directions for us to obtain that sample. It can be used to check post-void residual. However, bladder scans have decreased the need for this. They do not have a balloon, and we're going to talk about that a little bit later, but the balloon is on the indwelling catheters and it actually helps keep the catheter in place and it's inflated in the bladder itself. And these are usually, our straight catheters are going to be a typical size of 12 to 14 French. So indwelling catheters, they're used for retention, to provide continuous bladder drainage, and are used to provide urine flow perioperatively, to closely monitor urine output of critically ill clients, and then we can actually assess their kidney function as well, tying in some fluid and electrolytes here, to protect skin from urine, especially if somebody has extreme skin breakdown. It can help allow us to keep the area clean and dry, specifically in the sacrum. And when spinal and epidural anesthesia is given, this decreases the urge to void. With neurogenic bladder, due to, let's say, a spinal cord injury, and to address incontinence after all other measures have failed. To irrigate the bladder, and this would be used for a transurethral resection, to instill medications or fluids as well into the bladder. And it's most commonly a double lumen with a 5 ml balloon that would be filled with sterile saline or sterile water, depending on what is in the kit that you receive. One of our goals is to prevent catheter-associated urinary tract infections, or CAUTIs. This is one of our National Patient Safety Goals, NPSG, National Patient Safety Goal. We use these guidelines to prevent infections of the urinary tract that are caused by catheters. So what are some of these interventions that we can use to achieve these goals? The most frequent cause of nosocomial infections are CAUTIs, so we want to use urinary catheters only when they're necessary. Review the criteria for keeping a catheter with the nursing team daily, and including like our doctors and physicians as to why we need to keep that catheter in place. Is it necessary, and can we remove it? We want to insert using that sterile technique, the aseptic technique, to prevent the introduction of any pathogens. Use the smallest size possible, because if a catheter is too large, it can cause skin tears and damage while going in. Any breaks can have an increased risk of infection at that site. We want to maintain the system, make sure that we're using good hand hygiene when we're handling it, and encourage our clients to utilize hand hygiene practices as well. Maintain unobstructed flow, because if it becomes obstructed, the urine can actually back up into the bladder, increasing our risk for infection. Maintain a closed system whenever possible. So we don't want to detach the drainage bag and reattach it multiple times. Every time we're doing that, we're increasing the risk for infection. We want to keep the catheter or the drainage bag at the level or below the bladder. We don't want that backflow of urine into the bladder. Keep the bag off of the floor. Obviously, the facility floors are dirty. We're walking through different things. We keep it as clean as we can, but we always anticipate the floor is contaminated. Make sure that we're emptying it every 8 hours and as needed, especially if it's filling up. We want to use a separate clean container for each client. We're not sharing urinary containers to empty the urine into. And don't touch the spigot where the urine, where it's coming to the container. We want to make sure that we maintain that area as well. We avoid irrigation when possible, unless the catheter is obstructed. Disconnecting the catheter from the tubing, because again, the more we do that, the increased risk there is. We want to avoid replacing it routinely. We want to make sure that we're cleaning the periurethral area whenever possible. A lot of facilities will have it that we are cleaning the peri area every shift and as needed. So if a client has a bowel movement and they're incontinent and then there is stool around that catheter, we want to make sure we're providing really great catheter care. And we would want to replace the catheter as needed. If the catheter has been in too long and it's a higher risk for infection, we would want to replace it routinely, just not excessively frequently if we can help it. The increased times that we remove a catheter and put it back in, we're increasing that risk for infection. Make sure that we are using aseptic technique, and many institutions provide prepackaged wipes. So if you are at your clinical site, make sure you look for those. A lot of times it even walks you through on how the package expects you to use the wipes, similar to the bath in a bag. So again, we want to change the catheter only when necessary. Encourage the client to drink plenty of fluids, and Trace suggests 8 to 10 glasses of water per day unless contraindicated, which could be for somebody with a cardiac condition or renal disease that's unable to handle large volumes of fluid. The catheter balloon, it is filled with sterile water or sterile saline. You can see it in the image here. It is being held up. The reason it is filled with sterile solution is because if for whatever reason the balloon was to break inside the bladder, if it is a sterile solution that leaks out, it is not going to cause, the idea is that it won't cause harm to the client. Some catheter manufacturers and facilities no longer recommend pre-testing the balloon, which is where you would fill it with the solution and then pull it outside of the patient to make sure that the balloon isn't leaking and that it will fill up correctly. Most manufacturers no longer recommend this because it can actually create little ridges on the catheter itself that can cause more trauma when we're placing it. will get the opportunity to inflate a balloon outside of the patient in the lab, and you will be able to see with some of these catheters that have been used over and over again for practice that they do have ridges on them. Okay, contrasting female and male urinary catheterization. There is going to be a difference in length of the urethra. For men, it's about 8 inches. For women, it's 2 to 3. This is one of the reasons why it is easier for women to get urinary tract infections. Okay, locating the urinary meatus is easier in males and harder in females. You can mistake the clitoris for the meatus in female clients. The penis is held firmly and perpendicular to the bed. The labia on female clients are going to be spread gently but firmly before cleaning and inserting the catheter. Please note, as soon as you place that sterile gloved hand onto the client, you do not move it. It must remain stabilizing the site for the remainder of the procedure. If you remove your hand and let's say the labia close or the penis then touches the bed or touches a leg, touches anything, it is no longer sterile, and all that cleaning that you did is for naught. You've got to restart the whole thing with new gloves. So as soon as you plant that hand, you are one hand down. Please remember that. Okay, so the catheter would be inserted smoothly and quickly in females. It can meet resistance inserting in male clients due to possible prostate gland issues. And it's also a longer distance from the meatus to the bladder for men. Once you place that catheter, you keep going until you see urine in the tubing. You go a little bit further, and then you know that when you're inflating that balloon, it's going to be inflated in the bladder, not in the urethra. You don't want to blow up the balloon in the urethra. You will cause significant damage and pain to your client. Okay, stand on the client's side, right side if you're right-handed, left side if you're left-handed, because you're going to end up planting your non-dominant hand to stabilize the client when we're placing the catheter. Ideally, you want to set up the equipment while you have both hands available. So you're going to set up the entire kit and set up your field when you have both hands, because again, once you plant that one hand, you are down a hand and you cannot remove it from the client. So set up your equipment. Most of the time we'll set it up between the client's legs or on a bedside table. If you're unable to set it up on the client's bed, because let's say they're uncooperative, they're moving their legs a lot, then sometimes you set it up on the bedside table and have it right next to you so you can even pick it up, move it quick between the client's legs and place your catheter. Infection prevention continued. You want to cleanse the labia from front to back, top to bottom. You would make sure to use all of the swabs and or wipes depending on your kit. Some of the older kits will have cotton balls that you actually open an iodine solution and pour it onto. Once you get your sterile gloves on, you would want to make sure that you pull those apart a little bit because they stick together. And here you can see the nurse has one hand planted, spreading the labia, while the other hand is actually wiping everything. This is the technique that you will utilize for our female clients. The non-dominant hand is considered contaminated. Once it touches the client's skin, the labia must not be allowed to return over the cleaned meatus, even if it becomes slippery. So you really got to make sure you plant that hand and you do not move. For male clients, we want to make sure we're cleansing the meatus. Again, in this one, you can see in the image that it is the cotton balls that are being utilized, and they do tend to stick together, and they can fight back. If you have those at the hospital or at the facility that you're working at, just be mindful when using them. They tend to also fall out from the forceps, so that's always fun to deal with. If a client has a foreskin, it must be retracted for cleaning and replaced when the procedure is completed. Otherwise, you can cause severe skin and tissue damage, including swelling and edema and pain for the client. You would want to, again, make sure that you hold the penis perpendicular to straighten the urethra when we're placing it. And when we're cleaning it, we start at the meatus and work in a center motion moving out. And you would want to use all the swabs that they have in the kit. Usually it's going to be 3 swabs. Sometimes you might have a kit that has about 5 swabs, so be mindful of that. Okay, post-procedure care. We would want to tape the catheter or use commercially prepared device to fasten it to the leg. A lot of times they have little clips that you can actually hook onto the client's leg, stat locks that help hold it in place. What this does is it prevents movement of the catheter inside the body. The more the catheter is moving, the increase you're going to have increased irritation. It's going to pull, it's going to be uncomfortable, and it can actually cause inflammation on the skin at that site. So we want to place the bag over the leg, not under it. This avoids kinking and pressure and buildup. We want it to be able to drain freely. So if it's under the leg, it can become occluded. We would want the drainage bag kept below the level of the bladder, but not on the floor, and make sure that the system is kept intact. For care, we would want to make sure we're providing peri-care afterwards to remove any of the solution left on the client. And then we would want to make sure that we're providing peri-care daily with soap and water or the catheter wipes every day or every shift or as needed as well for the client. We want to encourage the fluid intake, PO intake of 2,000 to 3,000 mLs per day to keep that catheter patent and make sure that we're preventing infection. If it's flushing out, that usually helps. Again, as long as the client can tolerate that amount of fluid. We want to be alert to signs and symptoms of infection, including burning and irritation at the meatus, cloudy urine, elevated temperature, chills, and confusion, specifically in the elderly population. Some facilities will also have a sticker or something that goes either on the catheter bag itself, on the drainage bag, or it goes into the chart, and it would have documentation on it that includes date and time the catheter was placed, the reason that the catheter was placed as well. And sometimes it either goes on the bag or in the chart. Double check the facility that you are at. So inserting documentation, okay, on 3/13/20 at 10 a.m., post-void bladder scan revealed 500 mLs of urine retained, order obtained for a Foley catheter placement. Number 16, French Foley with 5 ml balloon inserted without difficulty, secured to the thigh, connected to straight drainage, immediate return of 550 ml of pale clear yellow urine. So the big things that you're noticing from this note, number 1, we have the reason why the client is becoming catheterized. This is one of the essentials of charting. We've got our date and time. We've got our catheter size in there, which is on the package for the catheter. So it's going to be right on the package. It'll tell you the size. 16 French is very, very usual size that we will utilize for clients. We have the amount of fluid in the balloon, because when you go to remove a catheter, you don't want to be surprised with how much fluid is in there. And then we have the amount, color, and character of the urine that came out and how the client tolerated the procedure. Removal documentation. So for this, you would want to make sure that you have the date and time that you're removing it, the catheter size that you removed, the amount of fluid in the balloon, the amount of urine that was in the bag, how much urine you removed from the client, and how the client tolerated it. When you're removing it, I highly recommend you place a towel underneath the client, or at least something to catch any urine. You have a washcloth in your non-dominant hand. You're going to end up attaching an empty syringe. You can alcohol prep the little the adapter piece to hook up to the lumen. Alcohol prep that, hook up an empty syringe that's clean, obviously. Allow it to pull back the solution naturally. You don't want to pull on it because that'll create some of those ridges that we talked about earlier. Once it's filled up, you would actually empty it out, reattach it, and make sure you get all the solution out. The reason I say this is sometimes somebody might say that they put in 5 mLs or 10 mLs, but what's actually in there is significantly more, and you don't want to start pulling that catheter out if the balloon is still full. So make sure the balloon is completely empty. Then you have a washcloth hanging out right over their peri area. As you remove the catheter in a smooth motion with the washcloth, you can catch the end to make sure that it doesn't drip anywhere. I also always recommend emptying the bag, the drainage bag, before you start this process. It'll just make your life a little bit easier, especially if it was really full. Okay, make sure that you bring your kits, that you are ready to come in to practice. You'll practice placing it, and when you're done placing a catheter, you can practice removing it. So it's a really good process. Make sure you bring questions and you're ready to go. Thank you.